Hello, my name is Sham Mailankody. I'm a multiple myeloma and cell therapy physician at MSK, and I'm here with Dr. Jonathan Keats from the TGen Institute in the City of Hope, and we're here at the International Workshop of GPRC5D Therapies in New York City. This is the second annual meeting, and Jonathan, what do you think so far of the meeting?
This first session was really good because we talked about things that are actually missing in most of the clinics around the country and around the world on how to assess which patients might benefit the most from one of these therapies. And as we're starting to appreciate more and more how often patients who do get exposed, particularly more to talquetamab at the time, because that's the lead agent in the field, how many patients have lost that target antigen. And as we move forward and need to decide who gets what when, being able to assess which patients are viable and is going to be really essential to optimize care outside of clinical trials.
And that brings up an interesting point, which I think is in the last 5 or so years, the clinical applications of our technologies and our preclinical science sometimes has outpaced, or at least kept as much with pace with the research. Which by that I mean we now have a plethora of treatment choices. We have CAR T cells, we have antibody drug conjugates, we have bispecific and maybe trispecific antibodies soon, and we have different targets as well, BCMA and GPRC5D. So the important question in the clinic is sequencing and which drugs to use first, or which target to go after, which modality to go after. And I think you very presciently, more than almost nearly 20 years back, talked about sequencing before all of these drugs were available and genomic evolution in the context of sequencing. So how do you see diagnostic testing helping us decide which drug or modality to use and how to sequence these therapies best?
Yeah, I think there it's going to change how if you're viewing in the frontline setting, as I think all of us acknowledge, most of these agents are going to get approved in the frontline, or at least in first progressions kind of scenarios. So being able to assess our targets available in those patients, in most patients they are, but that'll be really essential even at baseline. And then as patients progress, where now, as you mentioned, like the research on how the drugs work and mechanisms of resistance has, in the immune therapy space, been amazing compared to all the other therapies that we did. We really understand what leads to a patient no longer responding. And bringing that from the genetics to cell surface protein expression, I think the last one that's going to really help clinicians like yourself make those decisions is now also going to be assessing the immune system to know, is this patient a good candidate for a CAR T versus a T-cell engager versus an ADC, because the immune system's not going to be there to assist. And how you'll cycle them at those different times will really change. Like, I'd imagine in your clinic, you have those patients that you're sitting there scratching your head and going, okay, you've seen A, B, and C, and D. What is the right thing for my patient today? And a lot of times we're just acting on best, most likely statistics, not that patient's actual profile, because even advanced like MSK, City of Hope, we don't always have access to these diagnostics today.
And I think the panel discussion, several speakers, including yourself, I think brought up important concepts about how these testing might influence sequencing. So, for instance, I think an important problem that we'll face in now and in the near future, given that I think second line and third line, almost all patients will now be treated with BCMA, or many patients will be treated with BCMA therapies. With the new approvals that have come in the last year, we have bispecific antibodies, CAR T cells, and ADCs are all now approved for patients with early relapse. And so that means then, unfortunately, that when patients get these treatments and eventually relapse off of a BCMA treatment, a critical question will be, can we give them more BCMA treatment, i.e. if they've progressed after cilta-cel or ida-cel, a BCMA CAR T cell, can we retreat them or treat them with a bispecific antibody or ADC, or should we be switching targets to GPRC5D? And I think that's a question that many of us will increasingly face with the availability of all these different agents. How do you think diagnostic testing will help us resolve this? In other words, can we re-target the same target, or should we change the target?
I think it will fundamentally change our basic tenets of the clinic, right? Classic basic tenet was, if a patient's been exposed to that agent and they progressed, you don't go back.
Yes.
And I think now, as we understand, especially from the immune therapies, the target is no longer on the tumor cell, well, you can't go back. Or it is there, now you have to make a decision of the modalities, because even most of these targets we have, like in clinical trials for all of them, we have CAR-Ts, we have T-cell engagers, and we have ADCs that, again, give you, if the target's present, now you have to pick which of those three pillars is going to give you the best response. That's one parameter, but also which one's going to work for that patient, because it might not be the one that works for the best for everyone may not work for that patient. And we will work towards those ways of defining that. I think that's the one of immune assessment. I think target assessment is something, it's just a matter of making reagents commonly available, standardizing how people interpret those things across clinics to then decide who's the right patient for the right agent.
The other dogma in the field for the last several years has been, all other things being equal, if you want to go after a target, let's say BCMA or GPRC5D, that a CAR T-cell provides more advantages over a bispecific antibody. However, in the last few months, we have data now from Majestic-3, for instance, which was a trial, albeit in BCMA, with DARA and teclistamab compared to standard of care, and then CARTITUDE-4, where cilta-cel was compared to the same standard of care. These are now cross-trial comparisons, but many people were quite struck by how impressive the data for DARA-TEC look like, perhaps arguably reaching similar levels of responses and efficacy as cilta-cel does. So, which raises a question then, are we really certain that the efficacy of CAR T-cells are superior to bispecifics, or are they more comparable to each other? Which then leads to the next sequencing question, which you alluded to as well, which is which modality to go after. And do you think it would be different for different patients, or can we come up with kind of a more uniform rubric for saying everybody gets a CAR if they can get a CAR, or are there patients who would benefit from an alternate modality more, all other things being equal?
Because I think those things, I hope, will resolve some of those. Again, I like a lot of people seeing those early data from CARTITUDE-1 showing 30% of patients being disease-free at 5 years adds to those arguments that we had as CARs came into the field that a CAR has potential for curative. I would, from the genomic side point, we see so much more tumor-acquired resistance in the T-cell engagers, which I guess thinking more of like how we measure microbial resistance to different antibiotics. Usually the better the drug, the more you start to see genetic resistance. So I almost think at some levels, the fact that we see such aggressive resistance coming out in T-cell engagers might argue that they're better. I think the clinical data for some of those early studies to see that final endpoint, obviously we know they don't have the same overall response rate at the front end, but now when we're seeing things like the trispecifics and combinations, like you said, with daratumumab or combinations of two T-cell engagers, I think it will be really interesting to see how it spells out. I'd love to say we're going to be able to define it. I think, we didn't talk about it in this meeting, but understanding whose immune system is best for those different therapies, because there's inevitably, I think that'll be one of those things that dichotomizes who gets it. I think that's still a little bit more advanced research that we need to do.
And I think you mentioned that with the pace at which we've kept up genomic characterization of tumor antigen expression on the research side has been pretty impressive for these therapies compared to historical. But I do think we're maybe slightly lagging in defining immune fitness or immune health in a way that's clinically actionable. And that is probably the next frontier of challenges in terms of translationally understanding what T-cell fitness means. Is there such a thing as T-cell exhaustion? And if so, how do we measure it in a clinically actionable way? I think is going to be the challenge for diagnostics in the coming years.
No, and I think, well, again, a lot of times we talk about AI, and I think these are the kind of scenarios where AI-like tools will have a better opportunity because they can see patterns that we as basic, rudimentary, statistically oriented scientists will not see. That being said, I think one of the talks we did have was about how microbiome can influence the immune system. And I think where that type of approach has struggled to get into the clinic is because it's so diverse and inconsistent by study, inconsistent by center. And And I think that's where the immune system part, like I do worry that's going to be a really hard lift. Like when we're doing something, we do DNA sequencing. Is gene present or absent? It's a yes, no. It's a really clear diagnostic. It helps when I give you a report, yes, no. Yes. Now I know what to do, versus if I say it's 63% probability.
Yes.
I'm like, well, I still want to give that patient a CAR T because
it's 63%, not 100.
Yeah, I get 95% response rate, so I don't care about your 68%.
Yeah. I think the other challenge we're kind of addressing in the clinic now is particularly in the context of CAR T cell, is the fact that they're not readily off the shelf. Mm-hmm. So there's patient selection, there's apheresis and bridging considerations. So often if I see a patient today in clinic, it's not as if I could give them a CAR T cell tomorrow. That by the time they get a CAR T cell, it's about 6-8 weeks from now. And one of the approaches that a lot of people are now adopting, and we have some clinical data for this as well, of bridging, is to use a GPRC5D agent as bridging and for 6 weeks or 8 weeks leading up to a BCMA CAR T cell. From a genomic perspective, what does a brief duration of GPRC5D targeting as a preamble to a BCMA CAR T cell, what do you make of that strategy for bridging, and do you have concerns? Do you think it makes sense?
So we actually covered this in one of our recent meetings. From my side, my view, so again, a lot of things are multifactorial, but for BCMA, one of the things we think about is soluble BCMA inhibiting T-cell engagers or CAR T from being able to recognize the tumor. So one thing that, when we've talked about this, because we use talquetamab a lot in bridging to CAR T, is that it provides an opportunity to also do a little bit of quite effective tumor reduction over that month. But that also brings down that soluble BCMA level, making more tumor that's remaining visible to that CAR T or even another T-cell engager or trispecific. So I do think that kind of approach, there's biological rationale. The debulking actually does help that next line therapy, particularly when it's a BCMA-based therapy that can be affected by soluble BCMA.
And so this is also kind of interesting. I think the field has kind of gone on an evolution of thinking, given some of the toxicities we see with patients with high burdens of disease getting CAR T cells. When I first started doing CAR T cells, there was an idea that off-the-shelf CAR T cells would be great, no bridging needed. Now we've come a full circle to say, well, we actually do need bridging to debulk patients appropriately, as you said. Start with lower tumor burden, which potentially helps with efficacy, but also there's an increasing understanding, I guess, that also improves the safety of CAR T cells, such that in many of our practices now it's quite routine to try to give effective bridging therapy leading up to CAR T cells, whether that's talquetamab or DSUP-like chemotherapy or other agents that not only are aimed at just buying some time, but debulking so that patients don't go in with very, very rapidly proliferative, very high levels of disease. And so therefore, I think some of the delays that are inherent to autologous CAR T cells may not necessarily be as much of a disadvantage as once thought.
Yeah, and I think, again, this is very much for the BCMA side, and that really plays into the account.
And then last thoughts, I guess, in terms of practical considerations would be, is there an optimal washout period from these treatments? In other words, if I were to use talquetamab for bridging, since it's an antibody, longer half-life, do I need to be worried about giving a CAR T cells in close proximity within a week after stopping talquetamab, or treatments like talquetamab? Or would I be waiting for 2-3 weeks to allow for clearance of the drug? On the clinical side, I'll say we've not seen a big difference. We usually try to give a washout period of about 1 to 2 weeks, 2 weeks ideally, but sometimes if clinical situation dictates, then 1 week. And we've not really seen an additive toxicity or lack of efficacy from doing so. But any thoughts or perspectives on how you think about washout periods for these treatments, biologic agents particularly?
I guess the only example case I can say, because I was involved in counseling a family with a situation like this where we'd done whole genome sequencing on them and actually knew that BCMA was lost, but we really had ran out of options for that patient. And they had been on talquetamab for a while and had started to progress on it. And in talking with the family, they're asking, like, well, should we really try the CAR T? And we're like, well, there's clonal divergence, there's all these other issues. But one potential is that we are giving those patients a very active population of T cells that we know pretty rapidly can expand. And if you have those T cells now also having the opportunity to have some remnant T cell engager there, you are doubling up, bringing that target, not just recognizing BCMA, but those cells that are activated also have an opportunity to bind CD3 and activate. So from my side, again, I'm not the clinician, but if you felt it was safe, you could see the biological argument that you actually could get additional benefit. And to be honest, most CAR T effectiveness is happening that first week to month of the treatment. So that little window where both are still present, I think you have the opportunity for an extra benefit.
And then to close out, I was going to ask, I think, there's a lot of new modalities of both diagnostics and treatments that are coming. We're hearing allogeneic CAR T cells, in vivo CAR T cells, trispecific antibodies, other ways of engaging immune system, for some of which we're already starting to see some very early clinical data. And similarly, I think diagnostics is improving as well. What are one or two things that you're most excited for the field, whether it's GPRC5D or more broadly in the coming 2 or 3 years that you think may have an immediate clinical impact on how we treat these patients?
Again, for more specifically things that I'm working on, I think it is that relapse refractory subset where a lot of patients have been exposed to many of these agents. And using technology that we're moving into the clinic and making available with, say, like in our case, it's the whole genome sequencing, we have a good opportunity to assess which patients are viable for some of these follow-on drugs that are targeting the same events. Obviously, we had here talking a little bit more about more classic pathology, some IHC and flow cytometry tests that also really will make it broadly available for people to start assessing in that late stage phase which agents are right for those patients. And I think in the future, when we move everything to the front line, we'll be assessing all those features and then asking the question of, for this patient, which of these combinations or which of these individual drugs is the best for that patient, as opposed to just setting a standard field where it's drug A, then B, then C. Yeah. It'll be a bit more personalized to that patient's tumors, because we definitely see diversity of like things like you have 1Q, your GPRC5D expression is a little bit higher than if you don't have 1Q. So there's some little subtle things that do have influence on the potential for therapeutic effectiveness.
Thank you, Jonathan. This was interesting, and hopefully we'll have a good rest of the meeting. We have one more day of interesting talks, so thank you so much.
Yeah, first session was awesome.